Hello, my name's Nick Majerison. This is Top Med Talk. EBPOM USA, Chicago 2018. ACOs are the only hope for affordable health care. That's today's talk, recorded at the recent Evidence Based Perioperative Medicine USA conference, or EBPOM USA for short. It was done in approximately 15 minutes, and it lays out the case for accountable care organisations, ACOs, as the only hope for affordable healthcare. It's presented by Fleisher, Professor of Anesthesiology and Critical Care, and also Senior Fellow at the Leonard Institute of Health Economics, the University of Pennsylvania. Have a listen.
Top Med Talk.
So it's my pleasure to introduce Dr. Lee Fleisher. He is the chair of the Department of Anesthesia and Critical Care at the University of Pennsylvania Health System, but he's also the senior fellow at the Leonard Institute for Health Economics. So this is definitely his wheelhouse. So Lee, I have one question. Do you wear a funny little hat like Saul does?
No, I don't.
A cheese head? Okay.
I am from Philadelphia, but we do have Ben Franklin bobbleheads.
All right, I'm going to hand it over to Lee.
Since everything at Penn is about Ben Franklin. So I'm going to switch a little, and it's interesting after the last lecture and the impassioned Brian statement that I come from a place that probably was one of the first to have a very robust PAT clinic under Bobby Traber, and my previous institution had a robust clinic at Reuven Pasternak, but I live in a place that has no pre-op clinic. So we can get into some of those discussions. I actually think, Saul, you're doing the right thing. But the question is, where is the needle going? And I'm going to talk a little from an economic standpoint, what I see and what some of my colleagues who've been educating me see as where we're going. I think population health is the right answer, and this was actually picked by Monty and Desiree, and talking about ACOs. Now, the interesting thing, being at the University of Pennsylvania, my CEO, who's retiring at the end of the year, will never say that we have an ACO, we're not involved in population health, but we actually care for 48,000 lives in a fully capitated way. So it's interesting. People are trying to deny what it is, but it's transitioning in lots of different places. So Saul talked about this. This was actually a publication about 10 months ago of the trajectory, and this is the burning platform that everyone sees, including the current administration. I'll talk a little bit about the signals that I'm getting from Medicare. And this idea that the percent of GDP is at 17.9, but the prediction in 2026 at the current rate is at 19.7. And in fact, the uninsured will continue to grow. And one of the questions is, are we focusing on the right thing? Saul, you actually, in many ways, talked a lot about health care, and I'll transition in this population health about health and some of the novel programs that are being thought of in places like Massachusetts. So you've probably seen this slide numerous times. I frequently show it was developed by Patrick Conway, who is now influencing significantly the state of North Carolina as the CEO of Blue Cross Blue Shield. And it's really going from this producer-centered incentive for volume, but all our CEOs are still seeing that the majority of their profit margin and their business is still incentive for volume. Still fragmented care, but they're trying to get there. When I talked a little bit about that question about pivoting to prospective payments, a lot of the problems of why we're not there is actually the insurers don't have the systems to do it. When I asked Blue Cross Blue Shield, can I get certain data? Can you actually give me a narrow network? Will you show me that it's good to send more patients to me? They can't do that. In fact, the only group that I'm aware of that's building that is Aetna, but even Aetna is 3 to 4 years away from prospective bundles. But we're trying to get to that new incentive for outcomes, that idea that 2 or 3% of our margin is in MIPS, MACRA, is in hospital-based, value-based purchasing. It is our profit margins of many of our hospitals, but it's still small compared to the potential up and downside to these systems and policies that I'll talk about today. Again, in this framework that Patrick Conway and others, and Marilyn Tavener, the former administrator for CMS, they really were looking for type 3, which are these ACOs, the bundled payments, the CPC, which I don't have time to talk about, and then finally is the population-based payment, which is occurring. Anybody here from Maryland? No. I'll tell you about Maryland. It is the future, potentially. And Johns Hopkins, everybody thinks that venerable institution is immune. They are really sweating the effect on the margin with the Maryland waiver. The thing that everybody actually has touted is this value-based purchasing approach has really reduced a lot of things like ventilatory-associated pneumonia, elective delivery. It's saved lives. And that a bundle is good. Now, the previous secretary of HHS, Tom Price, actually took away a lot of the mandatory bundles. What was interesting is he actually, when talking with people in the administration, believes in bundles. He just, as an orthopedic surgeon, didn't want to make them mandatory. So essentially, if a bundle helped you, you could make money. If a bundle hurt you, you could pull out. That doesn't work. And that doesn't work in the way we actually finance Medicare because it's got to be budget neutral. So the current administration, and Azor, really does believe in bundles. And you'll see a lot more bundles are options. They're still trying to figure out the regulatory issue. The problem that many people see in bundles, and this gets to the PASS clinic, but transitions to Mike Grocot's talk, is should the patient have surgery anyway? So if you talk to Comcast, and we have, about what they want from a center of excellence, they want Virginia Mason. They want someone to say that you don't need surgery when you don't need it, and you do when you do. They want to actually get the right patients to have surgery in which it actually makes a difference, and less low-value care, less back surgery on demand. Now, patients may want a lot of this, but that's what they're trying to drive through, and that's what didn't work under Hillary Care. When they started going the HMOs and U.S. Healthcare, which actually is located about 4 miles from my house, it was the HMOs were the ones saying no. So what did they do this time? It's the same plan. They just made the doctors say no. Very clever on their part. But that's essentially what you've had the pivot from HMOs to population health. So this is a very useful approach, and we talked about it, and Saul did a lot about that bundle. But the question is, and I think your PASS clinic probably does do some of this, so I'm sure it does, but it'll be interesting to hear Mike's perspective. So in an ACO, the question is, can we get to the health of the population? Can we reduce total costs of care by having some entity that includes doctors and hospitals, so the provider network actually is taking care of you? I was talking to an attorney at our law school who deals with social norms, and essentially what they are doing, and what's been the trend over the last 50 years, is that we've pushed the obligation for taking care of people from the federal government to the doctors and to their families. How many of you are aware of the 2 midnight rule? You aware of it? A few of you. So the fact is, you can't go, that right now, if you're not in 2 midnights, then Medicare can question you. So we called up Medicare and we said, there's a problem. And I had a talk with one of my colleagues who I helped train, who's inside Medicare, and I said, the 2 midnight rule, can we get to 1 night for safety? I mean, all these sort of total joints, the total knees, you just did something really interesting. You took it off of the inpatient-only list. So that means that it can now be done as an outpatient. They said, well, we don't think many of these will be done as outpatients, and there'll be no push for it, only the really healthy ones. Well, we all know that's ridiculous, that in fact the hospitals already are doing this. So they're pushing it on to the docs and their families to take care of these patients after surgery. So the question is, if you own that whole population, what can you do to actually reduce the cost of care? And that not only includes rational, doing a lot of things that Saul talked about in making them healthier from a medical care perspective and using a lot of it in analytics and disease management, aligning with who are you going to send your joints to for their post-acute care? Are you going to approve all of the rehab hospitals in your area, or are you going to say only a group? Can you activate them? And we might talk about that if there's time. There's been a lot of talk, particularly out of Penn, about patient activation and about behavioral economics. There's a phenomenal group in Italy. Is ERAS simply activating a patient to say, we're going to send you home? You know, we got 14 things, but how many of them really count? And probably the strongest thing is that activation of the patient. The other thing is that what goes into health, and this is what I was mentioning, and that's the interesting thing about ACOs, and do we have a role in this? And I think Saul and his clinic in some ways does in that question of pre and post. All these socioeconomic factors. In fact, as we're trying to determine those socioeconomic factors, the question is, what can we influence? There are places that, particularly Geisinger, that are teaching their diabetics how to shop. In fact, they buy their groceries for them, and how to cook them. So not just shopping, but they know they have to do everything. There are places that are sending people home with Blue Apron being delivered to make sure they're healthier. It's actually not about the individual, and we have to be careful that we don't actually get into equity versus socioeconomic effect. A lot of people are looking at dual eligibles. You hear that a lot for risk adjustment, special needs patients, which are patients on Medicare and Medicaid. But they also use race a lot. And that's the wrong thing, because in race, a lot of that may be some biases. The question is, what's your neighborhood like? Can you get fresh fruit? Is there a supermarket? Is there actually proper transportation? And that's what a lot of places are looking at in ACOs. In fact, if you look at the question, and it's interesting that I've heard some of the trusts, and our good friend Mark Hamilton is in a trust in which they've actually said the social budget should be combined with the healthcare budget. Because if you look at that in the U.S., we're the middle of the pack. We're just screwed up. We spend all this money on healthcare and so much less on social services. So as you think about it, population health is in part thinking about what we can do about those social determinants of health. Massachusetts has just enacted Mass Health. It's for Medicaid patients. They are giving additional money to the 17 ACOs throughout the state and saying, in those 17 ACOs, you have to actually partner with a community health organization, of which they've credentialed 10. And you can use that money for things that the community health organization thinks will be useful. And this morning I was texting with Patrick Conway, and actually this is the way North Carolina's going, which I'm sure he had a huge influence, and they spent $50 million, I think, this year on some of their social determinants. The interesting question is that a lot of people don't stay in the same insurance for very long. That's the problem in the U.S. The length that most people stay is about 18 to 24 months. And for ACOs to be successful, you've really got to stay in them around 13 months. And that's what the data is starting to say. That if they're only in it for about a year, and as you actually negotiate, and we've done this, negotiating, putting behavioral health individuals into our clinics, and we say that's going to increase our cost today. But a year from now, it's going to decrease our costs because we're going to have less opiate problems. We're going to have less depression, which affects cardiovascular disease. We may have higher medication compliance by having behavioral health workers. So it really is looking short-term, as Saul discussed, short-term investments for long-term gains. So I'll end so we can get to our questions. The thing that we have now is the next generation ACOs. This just came out about 3 months ago. It was an evaluation. These are the next generation ACOs. It began in 2016 with 18 participants. 2 more have been added, 5-year period. What you can see is a couple people actually spent more since they started in the ACO journey, but lots of them spent less per patient, including some a lot less per patient. The average was actually a positive. That in fact, in these new generation ACOs with some of the credentials, you see fewer acute care days, hospital evaluations, wellness visits are up, that they actually had a reduction in per beneficiary per month. That's PBPM, per beneficiary per month. You'll hear that a lot if you do insurance discussions. So that's where the ACOs are. That's where I think a lot's going. So we, as anesthesiologists, really need to get into population health because that's where lots of places are pivoting. So this is Maryland. So Maryland's a really weird state because they have had a waiver for years. They are not under the standard Medicare payment system. They are an all-payer state, which means that Medicare and all the insurers pay the same amount for a room day. Not for the docs and for other things, but for the room day throughout the year. And Maryland only allows you to make a certain amount of money for your hospital. So in effect, Hopkins can't make as much as a Penn because they're stuck in this system unless they have lots of foreign patients and out-of-state patients. Because if it's in-state patients, you actually see a decrease or an increase in the rate per day as the HSCRC, which runs this, looked at your profit margins from those patients. So what they did under the previous administration was actually say, we're now going to see how much you spend for the population that's attributable to your hospital. And we're going to give that to you next year. And if you take care of more patients, we'll give you more. Less, we'll give you less. If the health of that population changes, we'll affect that. But essentially, Hopkins and some other places have to make all their margin on the foreigners, which is decreasing, as well as out of state. But in 2019, they just accepted waiver number 2. And the second waiver is they're responsible for the costs of the doctors attributed to their health system. Now, at Hopkins, we all have practice plans, and we're all attributed, but there's lots of places that are outside and are still private. How do they treat them? And I know there are some people, I think, from anesthesia management companies here. The question will be that if the system is negotiating as a whole, and I actually am the lead physician for our $6 billion a year contracts, how aligned do we need to be with our system as more and more of these population-based payments come in? And if we're malaligned, and we're not doing things to decrease overall costs, how will they treat us? So I end with the triple aim. Thank you.
Top Med Talk.
Don't forget, of course, you can meet the Top Med Talk team. All you need to do is go to ebpom.org/meetings. Then you'll find some of the meetings that we will be in attendance at. And another way of keeping in touch with us, which we highly recommend, is the email list. Here's how you do it. Go to topmedtalk.com and sign up for regular email updates from us. We can then tell you when we are live on air via the website, because this talk that you've just heard, you may have heard it if you were listening to our live stream on topmedtalk.com. Occasionally, there's even unique content that is streamed on the website. So you may be missing out if you're not part of our email mailing list. topmedtalk.com to sign up. That's topmedtalk.com.